Hello, I'm Peggy Lavin. I'm a clinical social worker licensed in Illinois, and I'm the Director of Behavioral Marketing for Accreditation Guru, Inc. Before we start, I want to let you know that there might be slight pauses in my presentation. It will be me, not your computer, not your connectivity. I've caught a cold from my 3-year-old granddaughter. I've taken medicine, so if I need to cough, I'm going to try to mute and unmute. Connecting this strange introduction to our topic today, national accreditation, accrediting bodies expect a healthy environment, one that prevents and controls infections. So Zoom is a perfect infection control method. I can assure you that you will not catch my germs during today's presentation. So let's get started. So our agenda today, I'm going to do a brief overview of accreditation. I'm going to talk about CARF and Joint Commission as accrediting bodies, discuss the role of electronic health records in terms of accreditation, how it can be helpful, and a little bit on billing, and then share with you some lessons learned from our consulting with organizations, and finally, how Accreditation Guru can help with your accreditation needs. So very basic, we're going to start with what is accreditation? So an accrediting body accredits an applicant organization that demonstrates compliance with the accrediting body's accreditation requirements. These are standards of quality and safety. So when an organization seeks accreditation, it is going above and beyond state licensing regulations. It's going above and beyond to national standards focused on quality and safety. This type of focus, the national standards, results in improved agency administration and improved service delivery to the people provided care, treatment, and services, better documentation of clinical processes, better documentation of plans, procedures, policies. Accreditation is a great risk reduction strategy. So accreditation results in a better managed, a better operational organization. 3 main domains within accreditation are shown on this slide. The first domain is documentation. You might have heard the saying, if it's not documented, it didn't happen. And certainly accreditation bodies expect that there are written documents, both on the clinical level and on the organizational level. And looking at those documents, requiring certain documents are certainly part of the accreditation requirements. Another domain is the people domain. So the people that are being provided care, treatment, and services, and the staff that's providing the care, treatment, and services. Accrediting bodies expect that the staff are qualified and competent. And finally, the third large domain within accreditation is the facilities, the actual physical environment. So it may be an office for an outpatient program. It may be a suite of offices for an intensive outpatient program. It may be a campus for a residential program. Whatever the physical environment is, the accrediting bodies expect that that physical environment be safe, comfortable, and therapeutic. The relationship between the accrediting body and the organization is voluntary. The organization decides, I want to be accredited by this accrediting body, and applies for accreditation on a voluntary basis. The organization needs to demonstrate, as I've mentioned, compliance with applicable accreditation requirements called standards. And the organization needs to commit to continuous compliance with the accreditation requirements, with the standards. So accreditation is not just a snapshot at one point in time, but it's a commitment to continuously be in compliance with standards. Even though the relationship is voluntary between the organization and the accrediting body, there are some external factors that drive an organization toward accreditation. One of these drivers is private commercial insurance. In an insurance company, a managed care entity may require an organization to be accredited in order to be an approved provider, preferred provider on their approved panel. An insurance company, a private commercial insurance company, may require that a program or service be accredited in order to be reimbursed under an insurance policy. So private commercial insurance can be a very strong driver for an organization toward accreditation. In some states, the authorities give regulatory relief to accredited organizations. So for example, the state authorities may say, if you are accredited, we will come out and inspect you every 3 years. If you're not accredited, we're coming out every year and doing a state inspection. An example. The strongest driver for accreditation is a mandate for accreditation. And on the federal level, I have two examples here. One is that in order to be a certified opioid treatment program by the Centers for Substance Abuse Treatment, you have to be nationally accredited by an approved accrediting body within 1 year of operations. And those are basically methadone clinics. Another example of a mandate on the federal level is in order for Title IV-E funding to continue after 2 weeks for residential care, the residential program needs to be a qualified residential treatment program. And one requirement for a qualified residential treatment program is to be accredited by an approved accrediting body. So those are federal mandates that drive accreditation. State mandates that drive accreditation, I'm going to use Maryland as an example. So in order to provide mental health or substance use treatment in Maryland, you need to have a behavioral license issued by the state authority. To be eligible for a behavioral license in Maryland, you have to be accredited by an approved accrediting body. In some states, Medicaid reimbursement requires national accreditation. In some states, to be a certified community-based health, certified community behavioral health clinic or a community mental health center, you have to be accredited by an approved accrediting body. So these are very strong drivers for accreditation. Another driver might be a requirement from a national or state association. They may encourage or they may require accreditation to be a member. I can think of one national association, and you may be aware of this, the National Association for Therapeutic Schools and Programs, that is going to require accreditation of members by June of 2023, I believe. I know of another national association that encourages accreditation but doesn't require it of their members. But in order to serve on the board of the association, you have to be from an accredited organization. There is a state association in California that has required national accreditation for its members for many years now. I'm going to pivot now to talk about CARF and Joint Commission. I mentioned several times in the last few slides approved accrediting bodies. And for behavioral health care, providing mental health and/or substance use treatment, CARF and Joint Commission are probably the accrediting bodies most well-known. They're certainly always on the approval list, whether it's on the federal, state, or the insurance level. And so they're approved accrediting bodies for providing behavioral health care. We're going to start with similarities. And when I envisioned these slides, I thought that I would have two buckets. One bucket would be similarities, one bucket would be differences, and they would be separate and distinct. But then as I developed the slides, I realized that there was some leakage from one bucket to the other. So I will point this out as it occurs. So we're going to start with similarities, turtles and tortoise. So both Joint Commission and CARF have manuals. These are available to people who want to take a look at their accreditation requirements. They have both an electronic and a paper version. Different contents at times, but the two most important areas of information in their manuals are similar. And that is all of their accreditation requirements are in their manual. So very transparent in terms of what's expected of an organization. What are the accreditation requirements, which are called standards? The other thing that CARF and Joint Commission provides in their manuals, to be transparent, is all of their accreditation policies and procedures. So these are not the policies and procedures that they require you to have as a provider, but their accreditation policies and procedures. So it's kind of accreditation by CARF or Joint Commission A to Z. They call their accreditation requirements standards, as I've mentioned. And at a high level, there's two types of standards. One level is the common, what I call common core requirements. And those are standards that apply to all organizations seeking accreditation by CARF or Joint Commission. So it's like the foundation, common core. And then added to the common core requirements would be the additional requirements. Additional requirements may be added based on population, based on setting, or based on services. So if you are providing care, treatment, or services to adolescents, you would get additional standards related to treating adolescents. If you are treating that adolescent in a residential program, you will get additional standards related to residential level of care. If you are providing peer support services, or you are administering or storing medications, those are services. So those are added to the common core requirements. And that is the same for CARF and Joint Commission. They both conduct surveys. Prior to the pandemic, they conducted on-site surveys only. This is the opportunity for the organization to demonstrate compliance, conformance to the applicable accreditation requirements. Then the pandemic occurred and everything shut down. Joint Commission CARF stopped doing on-site surveys, and they developed a virtual survey process, which they used during the height of the pandemic. Currently, they are providing on-site surveying when safe and virtual surveying. Post-pandemic, and I certainly hope we reach that sooner rather than later, there is some conversation occurring both within CARF and Joint Commission that they might have a hybrid survey process that will continue post-pandemic. During a survey, the organization is to demonstrate compliance, conformance. For CARF, any standard that is not in satisfactory conformance results in what's called a survey finding. So at the post-survey, an organization will receive a report from CARF listing all the findings, all the standards that were not in satisfactory conformance. For the Joint Commission, at post-survey, a report is provided by the Joint Commission of the survey findings, and this is a listing of all the standards not found to be in full compliance. So they both have survey finding reports. The preparation for both CARF and Joint Commission is pretty much internal. You don't write or enhance policies and procedures and send them to CARF or Joint Commission. You do that, and then you're going to be reviewing those with the surveyors during the survey. So preparation is very similar. Another similarity between CARF and Joint Commission is well-trained surveyors. CARF and Joint Commission certainly spend a lot of time, effort, and energy training their surveyors, training on the standards interpretation, the survey process itself, very well-trained surveyors. Now, this similarity is an example of a little bit of leakage from that similarity bucket to difference bucket. So CARF describes its surveyors as industry peers. A professional that is with a CARF accredited organization can let CARF know that they have an interest in surveying on their behalf. If selected, CARF does all of their training for that professional, and then that professional is assigned surveys and conducts them on behalf of CARF. Industry peers. Joint Commission describes their surveyors as employed professionals. So Joint Commission hires professionals, trains them, and has them conduct surveys on behalf of the Joint Commission. For the Joint Commission's behavioral healthcare accreditation, these employed professionals are social workers, psychologists, behavioral healthcare nurses. Both CARF and Joint Commission, when you have your initial accreditation, takes about 2 months post-survey to receive the decision on whether you have successfully achieved accreditation. So it's kind of 2 months post-survey that you find out what the accreditation decision is. A cornerstone of both CARF and Joint Commission's accrediting experience is quality improvement, performance improvement. Both accrediting bodies expect on a continuous basis that the organization is collecting data, analyzing that data, looking for opportunities for improvement, taking action to improve, monitoring that the action they have taken does result in the improvement that they were looking for. So a continuous quality improvement aspect. And both accrediting bodies require an audit of clinical records. Are the records complete? Are the documents timely done, signed and dated? So both require an audit. Now we're going to change from the similarity bucket to the difference bucket, apples to oranges. Both CARF and Joint Commission have what we would consider a 3-year accreditation cycle. So once you're accredited, every 3 years, you will have a reaccreditation and a survey. Joint Commission has that 3-year accreditation cycle starting right with initial accreditation. So you have your initial survey, you are awarded accreditation, and that accreditation is for 3 years. A little bit of a difference is that CARF, just for the initial accreditation, if the organization on an initial survey is not in full satisfactory conformance, CARF might award a 1-year accreditation. But then thereafter, it's always a 3-year accreditation. So both Joint Commission and CARF end up being a 3-year accreditation with this slight difference in the initial accreditation experience. The next difference I want to point out is scope of accreditation. And this is a pretty significant difference. In fact, sometimes it's the deciding factor or one of the deciding factors in an organization choosing Joint Commission or CARF as their accrediting body. So for scope of accreditation, Joint Commission's policy is that all programs and services provided by the applicant or accredited organization are within the scope of services. So when I talked about facilities, I mentioned residential, intensive outpatient. So let's use that example. We have an organization that provides all 3 programs. For Joint Commission, all 3 programs would need to be within the scope. They would be surveyed. The expectation is that all 3 programs would demonstrate compliance to applicable requirements, and all 3 programs and services would be accredited and listed on the Joint Commission's website. In fact, the organization would be listed as an accredited organization. CARF's policy is a little bit different in that an applicant or an accredited organization can select the programs or services to be within the scope of the accreditation. So in our example, the organization would say, well, I would like my residential program accredited, but not my intensive outpatient, not my outpatient. Or I would like the residential and the IOP accredited, but not the outpatient, or all of them. So CARF's policy allows an organization to select the programs and services. End of day, those are listed on CARF's website in terms of which programs and services of an organization are accredited. Another difference is track record. And track record means how long do you have to demonstrate compliance, conformance with accreditation requirements. And CARF has a 6-month track record. So CARF's policy is that an organization needs to demonstrate 6 months of conformance to their standards prior to their initial survey. Joint Commission does not have a track record. Joint Commission's policy is that an organization needs to demonstrate compliance with applicable requirements starting the first day of the survey and has the infrastructure to continue in compliance going forward. So CARF has a 6-month track record. Joint Commission does not have a track record. This sometimes is a factor also in terms of an organization selecting either Joint Commission or CARF as their accrediting body. The next difference I have listed is standards, and you might recall I had that listed also in similarities. So this is another example of a little leakage from similarity bucket to difference bucket. Both CARF and Joint Commission have standards. Those are their accreditation requirements. CARF has standards, but with the standards, they also have intent statements and examples. Intent statements, guidance on how to demonstrate conformance, interpretation of a standard, background, rationale. Examples are just what you would think, examples of how you can demonstrate compliance to a particular standard. For CARF, the standards are scored, not the intent statements, not the examples, the standards, and the organization needs to demonstrate satisfactory conformance. Joint Commission, as I have stated, has standards. The Joint Commission takes its standards and divides the standard into what they call elements of performance. So a standard is a very high level performance expectation. And each of those standards are divided into one or more elements of performance, which are more specific, more detailed performance expectations. And it is actually the elements of performance that are scored. If you are in compliance with the elements of performance, then you're automatically in compliance with the standards. The standard. Joint Commission expects full compliance with each applicable element of performance. In the manual, so it shows the standards and it also shows the elements of performance. Once again, both CARF and Joint Commission are very transparent in showing the accreditation requirements. Surveys, again, this is an example of a little bit of leakage from the similarity bucket to the difference bucket. For CARF, it's usually multiple surveyors for multiple survey days. Joint Commission surveys for behavioral healthcare accreditation are usually one surveyor for multiple days. That was a little pause to take a sip and put some moisture in my throat. Post survey reports. So as I mentioned, you have a survey. If you are not in full compliance or not in satisfactory conformance, you have a finding and you get a report that lists all the findings from your survey. Then the expectation by both Joint Commission and CARF is that you are going to address each of the findings. For CARF, you are going to address the findings in a quality improvement plan. This plan is due 90 days post-survey report. So you get your report from CARF on the findings. You have 90 days to put together a quality improvement plan. This plan addresses each finding. It states the action that has been taken or will be taken. So it's a corrective action plan, the time frame, who's going to do it, what they're going to do, etc. And the implementation of the plan is reviewed during the next survey. Joint Commission's post-survey report is called an Evidence of Standards Compliance Report. And it is due 60 days post-survey report. So from the Joint Commission, you get your report of all the findings from your survey, and you have to develop an Evidence of Standards Compliance Report within 60 days, addressing each of these findings. Different than CARF, the Joint Commission's report is a corrected action plan. So you're not going to talk about what you are going to do. You have to talk about what you did do to get into compliance. Who, when, what was done, who reviewed it, who approved it. It's a corrected action plan. And you have to submit the Evidence of Standards Compliance Report within 60 days. It's reviewed by the Joint Commission, and if accepted, then the decision about accreditation is made. And hence, as I mentioned earlier, the 2-month period before you find out if you have achieved accreditation. So CARF is more of a corrective action plan, Joint Commission a corrected action plan. Fees. So both Joint Commission and CARF have an application fee, but their basic fees are a little bit different, and that is Joint Commission has two types of fees, an annual fee and a survey fee. An annual fee is invoiced every year. That's why they so cleverly call it annual fee. And a survey fee is invoiced after a survey. So the annual fee every year, the survey fee is after every survey, and minimally that would be one survey fee during the 3-year accreditation cycle. The actual fee is based on the types and numbers of programs and services provided, the volume of individuals provided care, treatment, or services, and the number of sites, physical locations. So an organization that has one program, one site, low volume, their fee is less than an organization with numerous programs and services, high volume, operating in many low physical locations. CARF has one basic fee, and that is the survey fee. And that is invoiced after the survey. And it's based on the number of surveyors and survey days. So when I give this information to people, sometimes people say, oh, so CARF might be less expensive than Joint Commission. Not necessarily. This fee structure, what it does, the difference really is that Joint Commission takes the cost of accreditation and distributes it over the 3-year accreditation cycle. It's not evenly distributed, but it's distributed over the 3-year accreditation cycle. CARF takes the accreditation cost and invoices it once during the 3-year cycle in the survey fee. So it's not necessarily the structure causes a difference in fees, but knowing what an estimate of fees would be for each accrediting body is a very important factor to consider when you're selecting an accrediting body. And so I always let people know that both Joint Commission and CARF are very happy and very easy to work with to get an estimate of fees. So if you would like to get an idea of what the cost of Joint Commission accreditation and the cost of CARF accreditation, you contact them, give them some information, and they will calculate an estimate of fees for you. So now we're going to pivot away from Joint Commission CARF, although I do want to say that I mentioned several times approved accrediting bodies. And for behavioral healthcare accreditation, CARF and Joint Commission are always on that approval list. They're probably the most used accrediting bodies in behavioral health. So we're going to pivot to the role of the electronic health record. And the primary role is to capture, and I'm talking about in terms of accreditation, is to capture the clinical documentation that's required by CARF and Joint Commission. So the electronic health record has to be the record that contains this clinical documentation for each individual's provided care, treatment, or services. This type of clinical documentation provides support for meeting eligibility requirements, eligibility criteria. It provides support for medical necessity, both admission medical necessity and continued stay necessity. It provides support, the clinical documentation provides support for the level of care. So again, I had mentioned our friend who has residential, intensive outpatient and outpatient, and the clinical documentation should support if the person's in the residential care as opposed to the IOP, or it supports being in a intensive outpatient level of care rather than a residential or outpatient level of care. So this clinical documentation supports and justifies the level of care provided. And I mentioned clinical documentation. So this slide provides you some examples of required clinical documentation by CARF and Joint Commission. This is not a comprehensive list. I just wanted to pull out some examples. So demographic information, of course, diagnosis, conditions, circumstances, medication. What medication is the person taking? To what effect? What medication has the person taken in the past? To what effect? Screening and assessments. Both CARF and Joint Commission have requirements for various screening and assessments. I didn't list them all here, just captured it in one bullet. But all of those screening and assessments need to be in the electronic health record. I did pull out one screening, which is for suicidal self-harm risk. And I pulled this out because both CARF and Joint Commission emphasize the need to screen every individual provided care, treatment, and services for suicidal self-harm risk. That screening, the results of that screening need to be in the electronic health record. Of course, the electronic health record needs to have the plan of care, treatment, or services. And I mentioned that the plan needs to be individualized and person-centered. This is a very strong, significant requirement by the accrediting bodies. So boilerplate plans where the same thing is repeated over and over again for every person will result in quite a few findings during a accreditation survey. The surveyors will be looking for an individualized plan, tailored, customized to the particular strengths, preferences, goals, and needs of a person, and that it's person-centered in that the person is very actively involved in providing information, participating in treatment, and planning discharge or transition. Any lab tests and the results of those lab tests needs to be in the electronic record. If you are administering medication, whether that is staff administration or self-administration, that medication administration, the record of that needs to be in the electronic health record. Progress notation. And then if a person is transitioning, again, using our example, maybe from intensive outpatient to outpatient, being discharged totally, that type of planning, that type of documentation needs to be in the record. An aftercare plan. What services will this person need after discharge? If you're going to provide it, what will that be? If you're going to refer them to another entity, another organization for aftercare, how are you going to facilitate that the person becomes involved and engages in that aftercare plan? So these are examples of the required clinical documentation by CARF and Joint Commission, and the surveyors are going to look for that in the electronic health record. In addition to the clinical documentation, Joint Commission and CARF also have organizational required written documentation. In fact, both of them very clearly have a section in the manual that says required written documentation, and it lists what standards, what accreditation requirements require written documentation. So again, this is not a comprehensive list, but examples of the required written documentation at the organizational level. Plans. So CARF has, I think, 6 or 7 plans, written plans that they require. Joint Commission has less than that. One common example for both is emergency preparedness plan. So what types of emergencies might occur? How do you prepare to mitigate the risk of those emergencies? How do you prepare for those emergencies? What do you do during those emergencies? How do you recover from those emergencies? This is all a written emergency preparedness plan that an electronic record system can help with. A code of conduct for staff, definitely written policies and procedures. Another example, a Joint Commission requirement is an organization needs to have a definition of sentinel event. A sentinel event is a catastrophic event that you would hope would never occur. But if it does, what is your definition for that type of event, and what actions need to be taken to minimize the risk of that happening again? Training is a very important accreditation requirement. The surveyors certainly look for all kinds of training when they're conducting their survey. The requirements address orientation. They address ongoing education and training. They address training for specific jobs and responsibilities, on-the-job training. All of that needs to occur. All of that needs to be documented and recorded. An electronic record system can help with that requirement. Part of emergency preparedness may be conducting emergency drills, fire drills, testing fire safety equipment. Again, an electronic record system can help with that documentation. I mentioned in the beginning that accreditation bodies expect that staff are qualified and competent, and this needs to be a well thought out system so that job descriptions describe each position, and for each position, what are the qualifications, what are the competencies, what are the duties and responsibilities that would be assigned to a person in that particular position. Job descriptions can also be converted very easily into performance evaluations. So these are examples of the type of required written documentation that the accrediting bodies, CARF and Joint Commission, expect to see on an organizational level. If they're not there, again, it's going to result in findings. How can an electronic record system help? Well, obviously, it can provide forms and templates to an organization, templates for policies, procedures, plans, forms for clinical processes, assessments, screenings, a template for plans of care, treatment, or service. Both CARF and Joint Commission expect that a person who's receiving care, treatment, and service has the right and ability, and there's a process to express dissatisfaction, a complaint form. An electronic record system can provide a form for that complaint process. Incident report. There may be occasions where those teens in the residential program run away, leave campus. That's an incident, needs to be documented. Might be an injury, it needs to be documented. So the electronic record can provide an incident report template. Electronic health record can be helpful in terms of billing, tracking billable services, and providing various billing tools. Now, how has the electronic health record helped in terms of accreditation? And I have to say, and as a social worker, I'm not proud of this, that clinical documentation in behavioral health historically was not top-notch. There were incomplete documentation, not timely documentation, critical information not in the record, and a lot of findings during surveys in terms of these problems and issues. Electronic health records have helped, and I'm giving just two examples here. One example is hard stops required fields. So you might in the past have had a professional that says, gee, it's really easy and I like writing down the diagnosis, but I'm, not really that excited about writing the circumstances, the rationale, the justification for this diagnosis. I'm going to move on and do something else, and I'll come back later and complete that. Life intervenes and they don't go back later and complete it, and you have an incomplete record, an incomplete documentation of that clinical process. Electronic records do not allow people to skip around. You don't move forward because of hard stops or required fields. You need to complete what's required. It prompts the professional to provide complete documentation. In terms of quality, I think electronic health records have certainly helped improve through clinical decision supports. And as you probably know, clinical decision supports are electronic records that have programs that prompt and help the professional implement particularly evidence-based clinical guidelines. So this help improves the quality of the documentation, and by providing prompts on evidence-based clinical guidelines, it certainly improves the quality of the care, treatment, and services provided. An example would be, we'll go back to our professional who's doing the diagnosis. So the professional says, okay, so here's the circumstances, here's some symptoms, and the prompt, the clinical decision support prompt might say, well, here's some diagnoses that relate to those types of symptoms and circumstances. And it prompts the professional to come up with a very accurate diagnosis. Or in the reverse, it might, the professional might say, okay, I'm looking at depression, and the prompt might then talk about the circumstances, the symptoms that justify a diagnosis of depression. It might be a level of care for substance abuse treatment. So the prompt might say, please talk about the withdrawal possibility, potential, talk about the biomedical conditions, talk about the behavioral and functional situation of this person, talk about the relapse risk. And then it may prompt to say, okay, based on the information you've just entered, this indicates a intensive outpatient level of care or a residential level of care. So just two examples of clinical decision supports and the significant impact they've had in terms of improving clinical documentation. And all of this is via the electronic health record. Another area that the electronic record has helped is in data collection. Both Joint Commission, and I mentioned this earlier, and CARF say you have to collect data for that continuous performance improvement process. And electronic health records have been wonderful in terms of helping collect data, both on an individual basis and on an aggregate basis. So for example, Joint Commission says you have to collect data on significant medication errors. And so the electronic record can say, okay, there was an error here. Johnny did not get his medication today. On an individual basis, that clinical documentation is there. On an aggregate basis, an electronic record system can say, and not only Johnny didn't get his medicine today, but 2 other residents didn't get their medications this week. So you've got 3 medication errors this week. And it can compare it to the past to see if there's a trend. It then helps you in terms of looking at how can you improve this process. Another requirement of both Joint Commission and CARF is outcome measurement. How is the person progressing through treatment? An electronic record can help with that outcome measurement. One specific way is the electronic record system can provide a library of outcome measurement tools. So you may be wondering, well, what's a good clinical outcome measurement tool for our population? And you can go to the library in your records, in your electronic record system, and you can take a look at tools. You might look at the BAM, or you might look at the PHQ-9 and say, well, I think that we need to explore this. This could be very helpful. So this library of outcome measurement tools has provided great assistance in the accreditation process. All of this has resulted in less findings of clinical documentation during surveys. And the 2 lessons that we've learned in consulting with clients, and this is in regards to electronic record systems, and we share this with our clients, is if you're going to convert from a paper system to an electronic health system, or you're changing electronic health systems, you want to do that very early in your accreditation process. The sooner, the better. You want to allow time for full implementation, staff training. You want to be assured that the system is running smoothly before your on-site survey. So the sooner, the better. The other lesson learned that we share is that with the paper record, you would have the surveyor and a clinical expert. And the surveyor would say, well, where is the screening for suicidal self-harm risk? And the clinical expert would take the record, open it up and say right here. And the surveyor then would quickly look at what they needed to look at, moving the survey along as efficiently as possible, which is very important in a survey, an accreditation survey. Now we tell people, when you have an electronic health record, have the clinical person there, of course, that expert, but also have a technical expert easily available and accessible, so that if there's a technical issue, the technical expert can come to assist quickly and continue that efficient survey process. And finally, just a little bit on Accreditation Guru, how we can help. So we are a consulting service. We are in our 13th year of consulting with organizations. We consult with behavioral health care, human service organizations, and our primary consulting services is in the area of accreditation. Initial accreditation, we help people maintain accreditation or get ready for a reaccreditation survey. If there's a conformance or a compliance challenge, we help with that. Those post-survey correction plans that I described a moment ago, we can help with that. We have a team of consultants that are experts in both CARF and Joint Commission accreditation. So we can match the consultant to your organization and your accreditation body. We can help you further with information about accreditation bodies and help you decide which one best meets your needs. In addition to accreditation, we also provide consulting services for strategic planning, for board development and training, and in the area of risk assessment. How do we help? We can provide accreditation kickoff. We do project management. We can review plans, policies, and procedures and map them to the accreditation standards. We can conduct a mock survey. We also can do facility inspections. If you remember in the beginning, I said accrediting bodies expect that facilities, the physical environment is safe, comfortable, and therapeutic, and we can inspect your facility to make sure that you are meeting the accrediting body's requirements in that area. We can do gap analysis. So what do you already have that's in compliance or conformance? How do you need to fill the gaps that you have? And we can provide training, both board and staff training. And that's how we can help. And now we're going to go to questions.
Peggy, beautifully done. Thank you very much.
Thank you.
Yeah, I have one question from Shannon. What is the cost of these services from Accreditation Guru?
Good question. Similar to the accrediting bodies, it depends on the programs and services, the volume, the physical locations. It depends on if you want a package, kind of all of the services that we can offer, or are there certain services, kind of on a case-by-case basis. And so just like the accrediting bodies, we would be happy to set up a time to learn more about you and to give you an estimate of the services that you're wanting to explore.
Excellent, excellent. And Peggy, if you wouldn't mind putting your contact information in the chat, we'd all appreciate that so we can reach out to you.
Definitely.
A question from Nancy. We are in the middle stage of implementing BestNotes. We have our CARF and reaccreditation, CARF reaccreditation in August, September. What will they review? Boy, Nancy, that's a good question. Just like Peggy outlined, they're going to review the documentation and specifically some of the data points that they're looking for within the clinical documentation. I recommend setting up a meeting with my colleague, Christina. And you can reach her at team@bestnotes.com. And she can do a brief analysis of where you are in terms of the standards that we're aware of. And we can give you a pretty good assessment of what they'll be asking for in August and whether or not you'll meet that standard by that time frame. Anything you would add to that, Peggy?
It sounds to me like you do an excellent job at providing a gap analysis. And I always call it mining for gold. So the gold is when you find that the organization already is doing something in compliance or conformance, but at the same time identifying gaps that need to be filled to have a good survey. So it sounds like a great service for gap analysis.
Yeah, and that's specifically from the EHR perspective. Other things outside of the EHR, Peggy's team would really provide that gap analysis really well.
Thank you for that clarification, John. You're right.
Yeah. Another question from Shannon. Also, when you say mock surveys, inspections, are those being done in person or virtually right now?
Well, that's a good question, especially in these times, isn't it, for the past over 2 years now. Prior to the pandemic, we were offering mostly on-site, certainly for facility inspections, on-site inspections. Some virtual, like people could certainly provide policies that we could review remotely and give feedback. Then during the pandemic, we went all virtual, of course, as almost everyone did. And now we're back to doing some on-site and some virtual. And, that's a conversation we have with an organization in terms of what works best for them. And so we hope very soon to get back to, on-site, certainly a facility inspection. And when I say facility inspection, particularly when you're talking about congregate living. So if it's a residential group home, any type of congregate living, it's best to do an on-site survey rather than a virtual survey. Although, during the pandemic, people got very creative and used a lot of technical equipment to check out the safety of facilities.
Fantastic. Peggy, another question from Renee. Would it be possible, or does it even make sense for a small private practice or corporation to apply for accreditation?
That's a great question, Renee. I have to say, my experience with both Joint Commission and CARF is that they certainly have a range, a wide range of organizations in terms of size, ranging from very small practices, 2 therapists and 1 office, to very large complex organizations. And the rationale to seek accreditation internally would be wanting an external review of what you're doing so that you know that it is meeting national standards of quality and safety. Externally, sometimes the smaller organizations have these external drivers that I talked about earlier. It may be funding requirements. It may be licensing requirements from a particular state. So in my example in Maryland, even if you are a small outpatient program providing mental health or substance use treatment, you need a behavioral license and you need to be accredited. So internal motivation would be an external review of your quality and safety. And then there may be external factors that would drive a very small outpatient operations to seek accreditation.
Excellent. Thanks, Peggy. A question from Nancy, just to follow up, will CARF also want to look at the 2 years of paper charts as well as the 6 months that they have within the EHR?
So my understanding is CARF's going to make sure that your records are in conformance for 6 months prior to that initial survey. And I'm not sure if you're asking something a little bit more specific than that. You mentioned 2 years.
Yeah, I think so. I think
the track record. Go ahead. Go ahead, John.
Please, Peggy.
I was going to say the track record for CARF, my understanding is it's 6 months prior to that initial survey. You need to show that your records are in conformance with their standards.
Excellent. I hope that answered your question, Nancy. A question, Nancy
may I say this, John?
Please.
Nancy, if that doesn't, well, Nancy and anyone that's listening, if you still need clarification or you want me to explore your question more, as I mentioned, we have a team of experts on CARF and Joint Commission accreditation. And I put my email address in the chat. I'm also going to share it on the last slide. And please send me an email and I would be happy to explore further or clarify further if needed. No problem.
Excellent. Thank you, Peggy. A question from Anthony. What reports are most helpful for an upcoming CARF survey?
Good question, Anthony. And I don't know if you're talking about organizational reports. I'm going to focus on that, but again, if I'm not quite hitting the nail, send me an email. But CARF looks for a written plan on accessibility, cultural competence and diversity, performance measurement and management plan, restraint seclusion, if that's used, restraint seclusion elimination plan, risk management plan, strategic plan, technology and system plan. So that's at the organizational level. CARF requires those written plans. Hope that answers your question. If not, as I said, shoot me an email and I will clarify further.
Excellent. If you have any other questions, please enter them into the Zoom chat or into the Q&A section. We'll give you a few seconds here in case you have a burning question.
And I want to thank my voice for doing fairly well.
You sound
Or
like
maybe I should write to the pharmaceutical company and thank them for their medication.
Yeah, you did great. You sounded great, Peggy.
Good.
Just one housekeeping item. Please join us again next week at the same day and time to see how BestNotes supports and maintains these accreditation standards. You'll use the same link that you received for today's session.
Any other questions, John?
One question here from
Okay.
Joshua. Can you please repeat those written plans?
Certainly. This is for CARF, and they require written plans for accessibility, cultural competence and diversity, performance measurement and management. If you use restraint seclusion, a restraint seclusion elimination plan, risk management plan, strategic planning, technology and system plan. And you might say, well, isn't Peggy clever? Well, this is right out of the CARF manual. As I said, both CARF and Joint Commission are very transparent, and they certainly structure their manual in a way that they hope to be very helpful to people working on preparing for accreditation. Any other questions, John?
Excellent. I just unmuted Michelle Newman. Michelle, do you have a question for Peggy?
No, I don't. I accidentally hit the button. I apologize.
Hey, no problem. Thanks for being here today.
Yep.
Hi, Michelle.
Hi.
Candace asked, the link for this recording will be emailed to us, correct? That is correct, Candace. We'll get that out to you later today or first thing in the morning. And Melissa asked, is there a way to get a copy of the slides from the presentation?
Certainly, if I provide them to you, John, will you make sure they get distributed?
We'd be happy to. Thanks for doing it, Becky.
I'm delighted.
I believe that are all the questions I have. Oh, question here from Vicky. Can a social detox be accredited?
Organization provides social detox. Yes. In fact, I can think of several that are accredited by CARF and by Joint Commission.
Excellent. If you can't see in the chat, Peggy, lots of thank yous from participants. Great presentation. I'll let you say any last words.
Okay, well, I just want to invite people to connect with Accreditation Guru. We're on Facebook, Twitter, LinkedIn. We also have some very interesting blogs on our website. So when you have time, I invite you to peruse our blogs and read ones of interest to you. And just like in chat, this slide has my email address and our phone number. We would be delighted to follow up in any further questions or further need for clarification that you have, or chat with you about your accreditation needs. Thank you so much for joining us today and spending part of your day with me. I hope the rest of your day is a good one.
Thanks, Peggy. Thanks, everyone. Take care.
Thanks, John.
You bet, Peggy. Bye.
Bye-bye.